All right. Thanks, everybody, so much. Those were really great talks. It really helps to get a more in-depth look at some of this data, even though I've seen some of it before. Getting everyone's expert opinion, you guys who know the data best, is so helpful for me as well. So I'm going to invite our panelists to come off, to turn on their videos, come off of mute. Unfortunately, Dr. Quinn Beasley cannot join us for the live Q&A today, but very happy to have Dr. Stokely and Dr. Brotherton here with us. Thank you so much. We have a thank you, and thank you to the audience. There's been a lot of great questions. You can put them both in the chat and in the Q&A, and we'll hopefully get to everything. I am going to start off. There are a bunch of questions about the NIS team data, and this sort of question of, we've been hearing so much about the drop in doses ordered over the course of the pandemic in terms of HPV vaccine dose ordering, and yet we're still not quite seeing any impact from that in the NIS team data yet for coverage. And can you go through that again?
Sure. Yeah, as many people noted in their questions, CDC's been monitoring vaccine orders, and we do this with the Vaccines for Children program. So we only have insight into the orders for the VFC vaccine, and that represents roughly 50% of the population. We don't have the information on the privately purchased vaccine. And what we have been seeing with the VFC orders is that there was a drop in orders for HPV vaccine, also for meningococcal and Tdap vaccines, especially in 2020 when the pandemic was declared and we had the shutdowns. We saw, a really large drop. Over time, we've seen some recovery, especially with Tdap and meningococcal vaccines. HPV is still a little bit lower than what we would typically expect pre-pandemic. So we were really surprised when we saw these results. We've been kind of bracing ourselves for a drop in coverage, anticipating that, and we didn't see it this year. We didn't see it last year, but last year, I think really the survey, it's a methodology issue. Most of our teams, like we said, had already started their series before the pandemic was declared. With this year, we thought we might see something. We didn't. We did with meningococcal and Tdap. And I don't know if it's because coverage was so much higher with those vaccines that the drop is more noticeable than with HPV. We're still investigating to really understand that correlation between the orders and what we see with coverage, because ordering is not necessarily administering. So we got to keep that in mind as well. We don't know how much inventory providers had on hand prior to the pandemic. That could have been part of their issue. They didn't need to order as much as they run through their stock. So there's a lot of things that may be at play. And on the good news, we're not seeing a huge drop. I think that's great. I don't think that means we're free and clear. I think we still have to be vigilant. Providers still should be checking vaccination status, encouraging vaccination, and making sure their patients are up to date with vaccines, with HPV and all other vaccines.
Absolutely. Thank you. I don't want to ask a leading question, but is it possible that some of the fact that we haven't seen, you're still seeing some gain because some folks are getting that vaccine earlier than, 11, 12, 13 when it's getting?
It's possible. We know vaccination at that age. I know it's new to be promoting it and encouraging providers to think about that age to administer the vaccine or to start the discussions. That could be playing a role. How much of a role, it's not clear. When we look at some IIS data, we still see administration at that age is still very small. It's a very small proportion of vaccination, but it is starting to increase. So that, that could help whatever impact could have be felt from the pandemic, that may be helping us address it, going forward.
Could be buffering potentially,
right?
In a way that you can't really do with Tdap because you really shouldn't be giving that anymore.
Right.
Right. Reminder. Dr. Brotherton, is that, what have you seen in Australia in terms of pandemic impact on rates?
Yeah, I think we have certainly observed similar to trends around the world. We had serious interruptions to our school-based programs. So in Australia, most HPV vaccine is delivered through schools. And of course, with school closures, there were serious interruptions in 2020 and 2021 as well. We have seen that, however, most kids are being caught up, so very intensive efforts have been made within our school programs to provide additional opportunities when kids come back to school, and also to let parents know in Australia you can also catch up any doses you miss at school through your general practitioner, so primary care physician, up till the age of 19, free of charge. So that's we're hopeful that as we routinely measure coverage by age 15, so we routinely vaccinate at 12 to 13. We're hopeful that by the time the kids impacted reach 15, they all will have had those opportunities to catch up, and so we're optimistic that the damage won't be too bad.
Great, thank you. A couple of other questions here that have come in through the chat as well. So one is about looking at the cervical cancer impact on HPV vaccination. There's a question here about US cancer registries. They don't capture stage 0 cervical cancer. Do you know if the international cancer registries are able to capture stage 0 cervical cancers?
Yeah, certainly some of them do. So stage 0 can also be called carcinoma in situ, but also the CIN3 lesions are technically the same thing. So we tend to separate them out into precancers. So for example, in Australia, they are not routinely reported in our cancer data, but they are very much reported out of our screening registries, which are designed to monitor rates of those precancerous lesions. And that's very much, you know, part of that initial evidence base of that the vaccines seem to be preventing cancer because they had already prevented those precancers. So I think some cancer registries also collect that data, but they certainly don't group them in with the cancers when they're reporting them.
Thank you. And following up on that, do you think that the decline in adenocarcinoma corresponds to the addition of HPV testing?
Yeah, I think if my understanding, of course, is with ecological data, you very much do need to know all the other changes that are happening. And that's obviously very true of the ecological data I showed from the US. And as you will have been aware, there were also changes to screening guidelines in a similar period. However, my understanding is that as per other countries, the youngest women, so those under age 30, are not using HPV-based screening. So I don't think we can attribute that decline, which is very much in that very young age group, to that. I think the bigger question is, could it be due to reduced screening in young women due to the changes in guidelines? Is probably would be my response to that. That's much more likely to be an explanation than HPV testing, you know, if we're trying to exclude other possible causes of that marked decline that you see in your data.
Great point. Thank you. Back to NIST. When I was looking at it, it seemed like maybe there was a narrowing of the gap between the rural and urban differences over time. Is that just because I was squinting? Is that a real thing, Dr. Stokely?
Well, numerically, yes, because it used to be around 14 percentage points. It's now around 9-ish, give or take. I don't know statistically if that is different, but it does look like it's narrowing. I mean, we've recognized that vaccination coverage in rural areas has been low for many years, and we've been trying to do more work in rural communities to promote the vaccine and help increase vaccine confidence, especially with HPV vaccine. Perhaps some of that work is paying off. Hopefully we can get coverage even higher in rural areas as well. So it's at least on par with the urban areas, if not exceeding.
Okay, thanks. And you do similar differences in rural, urban in Australia, and any suggestions for us in the US about what you've been doing there we could do?
Yeah. Look, I think we do have a very small gradient in particularly the completed course coverage. For us, it's really the remote areas that are the challenge, and they literally are logistic challenges about getting vaccine doses in communities at the same time the kids are there, and all of those sorts of challenges. So we don't actually have a very marked difference between our sort of, you know, more rural populations within large cities, and I think it's basically because they are school delivered. So we certainly have more challenges with, medical providers and other sorts of medical services in those communities, but they all have schools, and the way the vaccines are distributed through the school program means that they're pretty much on par with the major city coverage. So yeah, we don't really have that issue. We just have the big challenge of getting to kids who are living in very remote areas.
That last mile challenge. Yes, no, I love school-based programs. I'm a huge fan, super jealous of Australia. As we close up here, I'd like to know what's on your sort of HPV vaccine data wish lists. What would you like to see HPV data-wise? I'll start with you, Dr. Stokely.
I would just love to encourage all providers, all vaccine administrators reporting to their immunization information system so that we can improve data quality in the IISs as we get data in for CDC, that it'll help us evaluate coverage and administration in a more timely way. So that would be my wish list.
Excellent. A call to action for everybody on today. Fabulous. We'll take that and make a checkbox out of it. Dr. Brotherton.
Yeah, look, we have slightly different challenges at the moment. We do have great registries for both vaccination and sort of screening and cancer outcomes, but as I said, they're just not linked together. So for us, it's very arduous, takes years to get permission to link them, so I'd love to see better integrated data, and certainly we're working on that in Australia, but it's a real challenge for research, and any sort of real-time monitoring of impact at the moment is really difficult. The other thing that we really don't collect very well is different measures of ethnicity, and for other priority populations such as children living with a disability, how well we're vaccinating them. So there are definitely pockets in our population that I'm concerned about, maybe under-vaccinated, and our system doesn't collect great data to monitor that at the moment. So that's definitely on my wish list.
I think that's something we could work on too. So for all the early investigators out there, lots of things we can think about for data collection. Thank you both so much. Really appreciate getting to this moment to speak with you and gather all of your fantastic knowledge. And thank you for the work that you do so we can know how we're doing in our work as well. Appreciate it and hope to see you all soon. For everybody else, this is the end of session. What are we on? 2? And then we're going to go to session 3. To do that, you will end here and go back to the main page and then join back in for session 3. And we'll see you there soon.